Welcome to the first deformity lecture. Swan neck deformity involves the fingers. It is characterized by hyperextension of the proximal interphalangeal joint and flexion of the distal interphalangeal and metacarpophalangeal joint. It typically occurs due to damage to the volar plate. The swan neck deformity occurs due to intrinsic muscle contracture and dorsal subluxation of the lateral extensor tendons. Physiotherapy goals and interventions include reducing edema, improving flexibility in affected and unaffected joints, using splints or taping, and performing functional strengthening, endurance, and coordination exercises. Boutonniere deformity involves flexion of the proximal interphalangeal joint and hyperextension of the distal interphalangeal joint. The deformity is caused by the rupture of the central slip of the extensor tendon in the extensor hood. Treatment involves immobilizing the PIP joint in full extension for 6 to 8 weeks, with gentle active range of motion exercises starting at 4 to 8 weeks. Full recovery and return to activity may take several months. Zigzag deformity is characterized by a combination of thumb deformities, including hyperextension of the interphalangeal joints and flexion of the metacarpophalangeal joint. Hitchhiker's thumb involves hyperextension of the interphalangeal joint of the thumb and flexion of the metacarpophalangeal joint. Ape hand deformity is characterized by the atrophy of the thenar muscles, which causes the thumb to align with the second digit. This deformity results from median nerve dysfunction. Mallet finger occurs when the extensor tendon ruptures or avulses at its insertion into the distal phalanx. This condition results in an inability to actively extend the distal interphalangeal joint, causing it to remain flexed. Hallux valgus is defined as the head of the first metatarsal deviates medially from the body's midline, while the metatarsal and base of the proximal first phalanx shift medially, causing the distal phalanx to move laterally. The causes are varied, including biomechanical misalignment like excessive pronation, ligament laxity, genetic factors, weak muscles, and wearing shoes that are too tight. Physiotherapy. Goals and interventions are early use of orthotics and patient education. Later stages may require surgery, followed by flexibility exercises to restore normal function, strengthening exercises, and joint mobilization to address specific restrictions. Rear foot varus or subtalar varus or calcaneal varus is caused by abnormal tibial alignment, shortened rear foot soft tissues, or calcaneal malunion. The calcaneus remains rigidly inverted when the subtalar joint is in a neutral position. Physiotherapy goals and interventions are 1. Restoring proper mechanical alignment. 2. Enhancing flexibility in shortened soft tissues. 3. Orthotic fitting and educating patients on appropriate footwear selection. Rear foot valgus results from abnormal knee alignment, genu valgum, or tibial valgus. The calcaneus everts, while the subtalar joint remains neutral. The physiotherapy goals and interventions are the same as the rear foot varus. Genu valgum. Genu valgum, commonly known as knock knees, is characterized by an excessive lateral tibial torsion, causing the knees to angle inward and touch while the ankles remain apart. This condition often coexists with femoral anteversion. A normal tibiofemoral shaft angle is approximately 6 degrees of valgus. Excessive genu valgum shifts the weight-bearing force to the lateral side of the knee joint and can lead to lateral patellar positioning. Contributing factors include tightness in the iliotibial band, abnormal foot pronation, and femoral anteversion. Lateral subluxation of the patella is not uncommon in individuals with genu valgum. In contrast, femoral retroversion is more likely to result in genu varum or bowlegs where the knees bow outward. Genu varum involves excessive medial tibial torsion, leading to medial patellar positioning and a pigeon-toed foot orientation. Bilateral genu varum, both legs bowed, is frequently associated with femoral retrotorsion, while unilateral genu varum may be linked to medial degenerative knee disease or unilateral femoral retrotorsion. Excessive genu varum causes a medial shift in the weight-bearing force line,